All right, back again for another deep dive with us. And today we're going kind of surgical.
Ooh, exciting.
Yeah, you brought in a stack of textbooks and journal articles on abdominal wall incisions. And I got to say, this is some fascinating stuff.
Definitely an important topic.
Yeah, it makes me think someone's prepping for surgery rotations.
Or maybe they just like scalpels.
Maybe. Either way, we're ready to unpack all
Yeah,
this.
we're going deeper than just skin deep today.
Literally. And speaking of skin deep, did you know that where they put the incision can affect how well it heals? Like there's even an incision named after a swimsuit because it hides so well.
Interesting.
But we're getting ahead of ourselves here. Before we even get to talking about specific types of incisions, what are the core principles behind planning out a good incision?
Well, any surgeon will tell you it's not just about getting to the organ, it's a whole balancing act. You need accessibility, a clear path to whatever you're trying to get to, but you also need extensibility so you can make it bigger if you have to, without causing more harm.
Right, and you can't just go slicing and dicing through there, right? You have to think about the anatomy.
Yeah, preserving function is super important. Minimize the damage to the muscles, nerves, and blood vessels so the patient heals well and so they can actually use their abs after.
So it's not just about what happens on the table, it's about how they recover afterward, too.
Exactly. And then there's security. It needs to be strong so it doesn't open back up or, cause a hernia.
Hernias are no fun.
Yep.
Okay, so accessibility, extensibility, preservation of function, and security.
That's right.
Sounds like planning the incision is like almost as important as the surgery itself.
It's a big deal. It's one of the first decisions a surgeon makes, and it has a huge impact on how the surgery goes and how the patient recovers.
Okay, so let's say the surgeon's chosen the best incision for the job. What happens next? Walk us through the pre-incision steps.
Well, the first thing is prophylactic antibiotics. They give those within an hour of the incision to prevent infections. Simple step, but really important.
And then there's that whole thing, scrubbing the hands like in the movies.
Actually, it's gotten a lot simpler these days, but just as effective. Now it's preoperative antiseptic wipes. Some people even say you don't even need to do the soap and water wash before.
Less drama, more evidence-based practice.
That's the trend.
What about hair removal? Do they always shave the area?
Only if they have to. The main thing is they don't want hair getting in the way when they close the wound. And if they do remove hair, they use clippers, not a razor, so there's less chance of little cuts that could get infected.
Makes sense. And then come the drapes, right?
Yeah.
To keep the surgical team safe.
Yeah, they act as a barrier.
Barrier from the,
Exactly. And then good lighting is a must. Gotta be able to see what you're doing.
So we're prepped, we're draped, we got the spotlight, time for the incision. But is it always a scalpel?
That's a great question, and you might be surprised, but not always. Electrosurgery is pretty common too, and studies show it's just as safe as a scalpel when it comes to infections. Plus, it cauterizes as it cuts, so less blood loss.
Two for one.
Exact and cauterize.
Cut and cauterize. Nice. Okay, so we've made the first cut, bleeding's under control. Now let's get into the real stuff here, the different kinds of abdominal incisions. And we'll start with the basics, the longitudinal ones.
Yep, those are the ones that go up and down vertically. And the most common is the midline incision. It's the go-to for exploratory laparotomy, especially in emergencies.
Why is that the one for emergencies?
Speed and access. When every second counts, the midline incision gets you into the abdominal cavity the fastest. They can assess and control bleeding really fast.
So it's the get in there and figure it out incision.
Exactly. And it uses this cool anatomical feature, the linea alba. It's a tough band of tissue right down the middle, and it doesn't have a ton of blood vessels.
So less bleeding when you cut along that line.
Right. Less bleeding, less risk of hitting nerves. Good example of that preservation of function we talked about earlier.
Okay, so walk us through how they actually do a midline incision.
So they cut through the skin and the fat underneath, carefully find the linea alba, and cut through that. Now, below the belly button, you got to be extra careful because the bladder's right there.
You don't want to nick that.
Not ideal, no. Once they're clear of the bladder zone, they move the fat aside to expose the peritoneum. That's the lining of the abdominal cavity. Then a small cut in that, and they're in.
So from there, they can explore and do what they got to do.
Yep.
It sounds pretty straightforward when you lay it out like that, but I imagine there's a lot of, skill involved.
Oh, tons. It's like a dance between the anatomy, the goals, and keeping the patient safe.
So we've got midline for emergency access. What are the other longitudinal incisions?
There's paramedian, which runs next to the midline, just a bit off to the side, and then pararectus, which goes right along the edge of the rectus abdominis muscle, the six-pack muscle.
Why would they use those instead of the midline?
Well, sometimes you need more room to work up in the upper abdomen, and those incisions can give you that, but they don't give you as much access to the other side of the pelvis, and there's more risk of hitting blood vessels and nerves that are by the rectus muscle.
So more risk, less access, not ideal.
Not really, and pararectus has another big downside. It can cause the muscle to atrophy because it disrupts the nerves that go to it.
So weaker abs after surgery.
Yeah, could happen. So they try to avoid it unless they really need to use it.
Makes sense. No one wants weak abs as a souvenir.
Right. It's all about weighing the risks and benefits.
So we got the straight ones, the longitudinal. What other ways are there to get into the abdomen?
Well, next up, we've got oblique incisions. Those cut at an angle, and they're often used for specific procedures, like the McBurney incision. That's the classic one for appendectomies.
Oh, yeah, I've heard of that one. That's named after a swimsuit, right?
Actually, no, that's the Pfannenstiel. We'll get to that later. McBurney's named after the surgeon, Charles McBurney. He came up with it way back in the late 1800s.
Oh, okay. What's so special about the McBurney then?
It's all about minimizing damage to the abs. Instead of cutting right through the muscle fibers, it separates them, following their natural direction. It was a pretty big deal back then.
Working with the body, not against it.
Exactly, and it means less pain, better healing, less risk of hernias. I even read that Dr. McBurney bragged about a 0% hernia rate with his incision.
Wow, that's impressive. Shows how far things have come.
Definitely.
What other oblique incisions are there?
There's also subcostal and thoracoabdominal. Those are for getting to organs up in the upper abdomen and side, like the liver, gallbladder, even the kidneys.
So more specific incisions for specific organs.
Yep, they work really well, but they can be more painful and they might not look as good after they heal compared to some of the others. But again, it's always a trade-off.
All right, longitudinal, oblique, what else is there?
Last but not least, transverse incisions. Those go across the abdomen horizontally, and people like them because they look good when they heal. They follow the natural lines of tension in the skin, called Langer's lines, so you end up with thinner scars.
So they go with the flow.
That's a good way to put it. They're used for a bunch of different procedures, and sometimes they'll even add one on to a midline incision if they need more room to work, but they're really popular for pelvic surgeries.
Is that where we finally get to the swimsuit incision?
You got it. The Pfannenstiel, named after the German gynecologist Johannes Pfannenstiel, who made it popular back in the early 1900s. It's the classic bikini line incision, and it looks great when it heals, plus it's strong and closes up securely.
No wonder it's so popular, but I'm guessing there are some downsides.
Of course, it's mostly used for pelvic stuff, and it's not great when you need to work fast.
So not for emergencies, but good for planned gynecological surgeries. What other transverse ones are used in pelvic surgery?
There's the Czerny incision, kind of like the Pfannenstiel, but they detach some tendons to get even better access to the pelvic organs. But it's a little trickier to close. You got to be careful.
Sounds pretty complex.
It is.
And then there's the Maillard, right?
Yes, the Maillard's different because they actually cut through the rectus abdominis muscles. They don't just separate them. It gives you great access, but you got to be really careful to ligate the blood vessels.
Ligate meaning?
Tying them off or sealing them so they don't bleed. It's important in any surgery, but especially with the Maillard because you're cutting through some big vessels.
So it's a powerful incision, but with more risk.
That's right. It's not for everyone, especially people who have bad circulation in their legs.
So Pfannenstiel for looks, Czerny for access, Maillard for when you absolutely got to get in there, but with caution.
Exactly. There are a couple more, the Kusner and the Turner-Warwick, each with their own pros and cons.
It's amazing how much goes into picking the right incision.
It is.
They have to consider the surgery, the anatomy, the patient's history. Shows that surgery is an art as much as it is a science.
Absolutely.
Speaking of art, you mentioned the Pfannenstiel and how good it looks after. Do surgeons think about that? Like how the scar will look?
Oh, yeah, definitely. Especially for incisions that you can see. They want their patients to heal well, physically and mentally. A well-placed incision done well can make a huge difference for the patient's self-esteem and confidence.
So it's not just about function, it's about the whole experience.
Exactly.
That's been so insightful. We've gone from the basics of planning the incision to all the specifics of longitudinal, oblique, and transverse incisions. I almost feel like I could teach a surgery class.
Almost.
But before we move on to part 2, I got to ask, What happens if someone needs another surgery in the abdomen? Do they just make a new incision?
Ideally, no. They'll try to use the same spot whenever they can. Creating new incisions near old ones even years later can cause problems with blood flow to the area and make complications more likely.
Like the surgical version of reduce, reuse, recycle.
You could say,
Okay, so they try to reuse whenever possible. What about obese patients? Anything special for them?
yeah, definitely. With obese patients, they got to be super careful to avoid making the incision in a skin fold. Those folds can get moist, which is a breeding ground for bacteria.
So placement is key. How do they do that?
Couple of ways. They might pull down the pannus, that's the extra skin and fat that hangs down, to make a clear space to work. Or sometimes they'll do a paniculectomy, which removes the pannus completely.
Wow, I can see how that would help in the long run too, not just for the surgery.
Oh yeah, it can be life-changing.
What a fascinating deep dive into incisions. And I can't wait to keep going in part 2. But before we go, anything else our listeners should know about all this?
I think the main thing is that choosing the incision is just one part of surgery. It's a complicated decision, and surgeons have to think about a lot to make sure things go well for their patients.
Good reminder that there's more to surgery than meets the eye.
That's for sure.
We'll be back soon with part 2 to explore even more about abdominal incisions. Until then, stay curious and thanks for joining us.
See you then.
Welcome back. We talked about all these different ways to, get into the abdomen, but I'm wondering, with all the new technology, are these open surgery techniques going away?
That's a good question, and I think a lot of surgeons are thinking about that too. Laparoscopic surgery, where they use tiny incisions and cameras, that's really changed things. Less pain, faster recovery, it's great.
Yeah, it seems like the obvious choice, so why not do everything laparoscopically?
Well, there are a few reasons. Not everything can be done that way. Sometimes it's just too complex, or the surgeon needs to actually feel the tissues, see things directly, not just through a camera.
So for some things, open surgery is still the best option.
Right, like complex cancer surgeries, when they need to make sure they got all the cancer, that often needs open surgery.
I see. So it's not just about what they can do, but what's best for the patient.
Exactly. And, even when they plan to do it laparoscopically, sometimes things happen, complications, and they have to switch to open surgery in the middle of it.
Yeah, got to be ready for anything.
That's why open surgery techniques are probably always going to be important. It's like the foundation of surgical training so they can handle whatever happens.
So it's about having all the tools and knowing when to use which one.
Exactly. And speaking of tools, remember we talked about scalpels and electrosurgery? Well, there's new stuff coming out all the time.
Oh, I bet. What are they using now?
There are these ultrasonic energy devices. They use vibrations to cut and seal the tissue at the same time. Super precise, less damage to the surrounding stuff.
Fancy.
Right. And then there are laser scalpels that use light to cut, really accurate. Those are good for delicate procedures where you don't want a lot of bleeding.
From scalpels to lasers, that's amazing.
What do you think the future holds for all this?
Honestly, who knows? But I bet we'll keep seeing more minimally invasive techniques and more personalized medicine. I've heard about robotic surgery, where the surgeon controls tiny robotic arms. That's getting pretty popular.
It is, yeah. Robotic surgery is cool. It lets them do really complex stuff really precisely.
Like having superpowers.
Kinda. And the systems have these high-def cameras that give them a 3D view. It's like having superhuman vision, too.
Sounds futuristic. But I guess there's still some downsides, right?
Oh, yeah, for sure. It's still new, so it takes a while for surgeons to learn how to use it. And the equipment's expensive. Not every hospital has it. Plus, like anything else, it can malfunction.
So it's not perfect, but it's definitely changing things.
Definitely. And I think we're just starting to see what it can do.
So open surgery is not going away, but technology is changing things. It makes me think about those specific incisions we talked about. Do you think laparoscopy or robotics will change those or even lead to new ones?
It's a really interesting shot. One of the main goals of minimally invasive surgery is smaller incisions. Like, instead of a big cut for gallbladder surgery, they use a few little ones, less than an inch. Less pain, less scarring, faster recovery.
So those traditional incisions might become less common.
Maybe for some procedures,
Yeah.
but even in laparoscopy, they still have to make incisions, just smaller ones. And those incisions still have to be planned carefully, thinking about those same principles: access, extensibility, function, and security.
So the basics are the same, even if the tools change.
Right, it's like you get new paintbrushes, but the rules of painting are still the same.
Good analogy. So maybe it's not about getting rid of those old incisions, but making them less invasive.
Exactly, and I think we'll see more innovation there. Like, there's research on using natural openings like the mouth or vagina to get into the abdomen. No external incision at all.
Wow, so surgery with no scars.
It could happen. It just shows how creative surgeons are. They're always trying new things.
Pretty inspiring.
Ah.
You mentioned robotic surgery. That seems like it has a lot of potential.
It does. One of the coolest things is how precise and delicate it can be. The robotic arms can move in ways human hands can't, so they can get into tight spots and do really intricate stuff.
Super-powered hands.
Yeah. And the cameras, like I said, give them amazing vision.
But I'm sure there are still limitations.
Of course. Like I said, it's new, so it takes a while to learn. It's expensive, too.
Yeah.
And like any machine, it can break down.
So it's not a perfect solution, but it's got a lot of potential.
Definitely.
Okay, so technology is definitely changing how surgery is done, but I'm also curious about how it's changing how surgeons think about their patients and about surgery itself.
That's a great point. I think in some ways, technology has made surgeons and patients closer. Minimally invasive surgery means less pain, faster recovery, so surgeons can focus more on how the patient's doing overall.
So it's not just about fixing the problem, it's about the whole patient experience.
Right, and I think it's also made patients and surgeons work together more. Patients have more information, they're more involved in making decisions about their care.
So it's changing the relationship too, not just the tools.
I think that's a good thing.
We've covered so much in this deep dive. Incisions, the history of surgery, technology, the human side of it all.
It's been a lot, but it's been fun.
Before we wrap up part 2, I have a confession. Remember all those incisions we talked about? I kind of have a favorite.
Oh.
Which one? The fan and steel. It's just so elegant, hidden down there below the bikini line, like something out of a spy movie.
I can see why you like it. It shows that surgery can be functional and beautiful at the same time.
Exactly. So while we've been talking about the pros and cons, they can be pretty cool too.
Yeah, they can.
We'll be back soon with part 3 to wrap things up and give you something to think about. Until then, keep exploring. We're back for our final peek into the world of abdominal wall incisions. From those early surgical pioneers to the, well, cutting edge of robotics.
We really have covered a lot, haven't we? All those different incisions, the pros and cons, how technology's changing things.
And even the, like, human side of surgery. It's been amazing to see how it's both an art and a science.
It really is.
So as we wrap up this deep dive, what's the one thing you hope our listener takes away from all this?
That's a good question. I think the most important thing is to remember that even with all the technical stuff, there's a person at the center of every surgery. It's a big deal, and the decision to have surgery isn't something to take lightly.
It's not a small thing, that's for sure.
So if you're ever facing surgery, planned or emergency, remember knowledge is power. Ask questions, do your research, and don't be afraid to get a second opinion.
So be an active part of your own healthcare.
Exactly. You have the right to be informed and involved every step of the way.
It's a good reminder that even with all the technology, the human side of medicine is still the most important.
Couldn't agree more. It's a partnership, the surgeon, the patient, the whole medical team. Trust and communication are key.
That's a great way to put it. Well, we've explored this amazing world of abdominal wall incisions, the history, the future, the technical details, and the personal stories.
It's been quite a journey.
To our listener, thanks for joining us on this deep dive. We hope you've learned something new and maybe even gained a new appreciation for the art and skill of surgery. Yeah. Remember, keep learning, keep asking questions, and always advocate for your own health.
And if you ever have more questions, you know where to find us. We're always ready for another deep dive.
Until then, take care.